Okay, it looks like it's top of the hour. Thank you everyone for joining us today for this webinar. Just a couple quick things before we get started. You can submit your questions throughout the webinar using the questions panel, and your certificates will be available this Friday by logging into your account. Darlene, if you'd like to get started, go right ahead.
Hi, good afternoon, everyone. Welcome. Thanks for joining. Thanks to Medela for offering me this opportunity to share some hard-won knowledge with you all. And just so you know my background, I have been a registered nurse for 35 years with a focus in women's and children's health. And it's hard to believe, but this is my 20th year as an IBCLC. So hopefully I'll share some pearls of wisdom and we'll move forward with the presentation. And let's see. Okay. Sorry, guys. Give me
You
1
should be able
second.
just to click on your
There
slides.
we
There you
go.
go.
Okay. Just having a little tech issue. All right. So the topic for this afternoon is kind of deciding when and how often to express human milk in the immediate postpartum period. Sometimes it's easy to make that call, and sometimes it's more challenging. Disclosure statement there for you all. I have no conflicts of interest to disclose. And these are our learning objectives, which I'm not going to read to you, but they're there for your review. And I'm kind of excited that this is August for me to present. It started out with World Breastfeeding Week, and this is National Breastfeeding Month, and the theme this year is Together We Do Great Things. So I hope at the end of the presentation we all kind of embrace how we can work together and do great things to promote and support families that are breastfeeding for their newborns. So as we're looking at when and how often, this comes up a lot. I'll come onto the unit in the morning and the nurses are like, hey, we had this mom, she delivered overnight. We're not really sure if we should start her pumping. Can you get in there and see her? And, you know, it's a little frustrating as a lactation consultant when you know the mom's been there all night and probably should have started pumping earlier in the evening. So I kind of had to sit down and think of ways to help the staff, the clinical folks that are working with the families in the immediate postpartum period, support the mother with that decision, when, if she should, how often she should. So what I want to kind of make sure we touch on are challenges that are related to the initiation of breastfeeding, because there are some real challenges. And again, sometimes it's obvious we need to assist a mother with initiating expression in the immediate postpartum period. So the baby had to be whisked away and taken to special care nursery or the NICU, or the baby may even be shipped to another facility that can provide a higher level of care. So in that scenario, mom and baby are separated, mom desires breastfeeding, and you go, okay, this is a no-brainer. Mom needs to start expressing. You may also have a mother that has some serious and significant delivery complications, and she may need to go back to the OR, or she's getting a massive blood transfusion, and skin-to-skin contact's delayed, initiation of breastfeeding's delayed. That in that scenario, she may even have to go to the ICU for a higher level of care. Mom and baby are going to be separated. You may have a mother with COVID and she is extremely ill on arrival. She's acutely ill and she's going to wind up in the unit after she delivers. So in those scenarios, it's kind of obvious mom and baby are separated and we need to assist them with initiation of expression. Now, the place where we're probably going to focus more today, this afternoon, is where it's not as clear cut. It's not as evident that we need to start mom expressing. So, all right. Now, it's natural and normal, but it's not always intuitive to breastfeed. Some families have more challenges than others. And there's plenty of literature out there. So if you've been reading, studying, working on protocols and procedures where you work, you know you should be familiar with the challenges. I'm not going to belabor them. But supporting families in making informed choices about expressing, when to express, how much to express, how often to express, and supplementation, it's important that we're helping the families make evidence-based decisions, not just something off the top of our head or something we did with our own children. So questions when we're looking at families, which families are at risk? That's an important question to ask. Who's going to benefit from expression? When should they initiate expression? What types of expression are going to be beneficial? Is this a mother who just needs to hand express a few drops of colostrum, get them on baby's lips and gums to help engage the baby? Or is this a mom who should be doing breast massage, hand expression, and using a hospital-grade breast pump to initiate her supply or help her with collecting enough colostrum, transitional milk to supplement her baby with? And then the other question to ask is, how frequently does she need to express? And what kind of supplies and support are they going to need, not just in the hospital, but as they're preparing to go home? So planning their discharge needs. And if you've been a nurse, you know, rule of thumb is discharge planning is taking place on admission. Rule of thumb. All right, so risk factors to consider with mom. Is she a prima para? It's going to be tougher for her if she's never breastfed before. Advanced maternal age, fertility assistant, PCOS, diabetes, those tend to be endocrine issues. If you've got a mom that's got a pre-gravid BMI over 30, she's at risk for low milk supply due to metabolic syndrome and potentially endocrine issues. If she's got a history of low milk supply with another baby, or she had a really negative experience with breastfeeding with another baby, history of breast surgery, if she had hypovolemia related to shock, it could be hemorrhagic, it could be septic, hypertension, that can be chronic or gestational, preeclampsia, eclampsia, HELLP syndrome, postpartum hemorrhage, retained placental fragments, chorioamnionitis, acute COVID infection. Cesarean births, operative vaginal births make it tougher. If nothing else, think about it from a mobility standpoint when you've had a cesarean birth, multiples. So if she's giving birth to 2 or 3 children, that is in and of itself a huge challenge. Painful latch, nipple trauma. Sometimes I have gone in to see women and they're in excruciating pain and they've already got some significant nipple trauma, nipple damage. And if mom has a history of anxiety or depression, that certainly can compound things. So let's move to the next slide. And let's think about the baby. So the interesting thing about lactation is we've got 2 patients to consider, and sometimes 3 and 4 if mom delivered multiples. So you've got near-term and preterm infants, and these preterm infants can be late preterm, moderate, very preterm, or extremely preterm. I highlighted them and changed the color in the background because they're the kids that typically wind up having issues with glycemic control. They tend to get hypoglycemic. You can also see where I kind of highlighted hyperbilirubinemia. Jaundice tends to be a problem. These kids tend to need, not always, some ongoing respiratory support, particularly the ones that are moderate, very, and extremely preterm. They also tend to have issues with suck coordination, tone, Not necessarily facial palsy related to being preterm or near term, but if we had a shoulder dystocia, prolonged second stage, things of that nature. Kids that are forceps vacuum assist, well, if you're kind of pulled into the world, so to speak, you may not be feeling too great and feeding great. Facial bruising, cephalohematoma, caput. Kids that are Coombs positive, you want to keep an eye on them because they are very likely to develop jaundice. Meconium stained fluid. They may be stable, they may be able to room in, but they may have meconium stained fluid kind of still in the nares. They may have it in the stomach. They may be spitting up, gaggy. They may not be feeding great. Kids that required some type of resuscitation interventions in the delivery room, they responded well and they were able to room in, but they may not be feeling great. They may not be feeding well. Cleft lip, cleft palate, conditions to craniofacial structure. Those children, depending on the level of care that you can provide at your facility, may be transferred out. So those moms are definitely going to need support with initiation of expression. Your healthy term infants, this is where the waters get muddied, so to speak. So I want you to think about a healthy term infant in the first 6 hours of life. Were there any antepartum or intrapartum issues? Were there any issues related to the delivery? Maybe the baby sustained some injuries. We're worried about a palsy, or they fractured a clavicle or their humerus. Are the dyad able to stay together? This is a big one. Are they going to be rooming in? Now, they're rooming in. Everything looks good. Baby's wrapped up, bundled up. So getting baby skin to skin and observing the baby at the breast. Is the baby maintaining a latch? And are they demonstrating bursts of nutritive sucking? Is the mother able to demonstrate effective hand expression? That's important. And a lot of times I go in a room and the nurse will say, yeah, she's expressing, but nothing's coming out. And I watch the mother expressing, and she's just squeezing the heck out of her nipple. And I'm like, ooh, we're hurting ourselves and we're not really demonstrating effective hand expression. So making sure mom understands what effective hand expression is, and making sure the nurse understands sometimes what effective hand expression should look like, so she can support mom with that. Sometimes I get the partner to help out too. Mom may be attached to, a blood pressure cuff, pulse oximeters on her fingertip, IVs in the other arm, and dad's willing to help out. But I warn dad, I'm like, listen to mom and make sure you're not squeezing too hard, because sometimes when the partner's trying to assist, they can be a little firmer, if you will. I try to explain to families that the breast is not a water balloon. It's more like a sponge or a gland, to help them understand. So that would be like in the first 6 hours. Let me go back. And in the first 6 hours, I kind of want to see it, for a healthy term baby, at least one good feeding, where baby latched, maintained the latched, and just demonstrated some really nice bursts of nutritive sucking. So 6 to 12 hours of life, are they still together? Are they skin to skin? Have they breastfed at least once in the first 6 hours with bursts of nutritive sucking? Is mom able to demonstrate effective hand expression? Sometimes you go back to the room and mom says, I tried to do what you showed me, but I can't get it. So we'll go over it again. Sometimes it's important to reinforce the teaching. And are they able to get drops of express colostrum on the baby's lips and gums and help baby get engaged? Might be a little support with positioning too. And at 12 to 24 hours of life, you're kind of asking similar questions. But now I want to hear this baby's breastfed at least 2 times in the first 12 hours of life. And I kind of want to check in and see how they're doing with hand expression, how they're doing with getting the baby latched and engaged. So that's something to look at 12 to 24 hours of life. Now, when you hit your 24-hour mark, there's some important questions to ask. And I think, one, are they still together? Are they skin to skin? Skin to skin contact is super important the first couple of days of life. And now I want to go back and look at where the feedings have been documented and kind of say, hey, has this baby breastfed at least 2 to 4 times from 12 to 24 hours of life? Which means if they breastfed at least 2 times in the first 12 hours and 2 to 4 times from 12 to 24 hours, I want to see at least 4 to 6 feedings, at least. If the baby breastfed more, that's fantastic. But because if I'm not seeing that, I need to start thinking about bringing in a pump and getting mom to not only continue her massage and hand expression, but throw in some pumping. So that's a question. Another important question at about the 24-hour mark, is the baby's urine and stool output adequate? And you want to look at weight loss at 24 hours of life. Is it within normal limits, as well as the baby's bilirubin level? So what I want to do is show you a tool, and some of you may be familiar with it. Some of you, depending on where you work at, may have it incorporated into your EMR, which is great if you do. But if you don't, you can go to newbornweight.org and you can share this with your pediatric providers. And I do this a lot, is I'll go in and say, hey, I went in and I saw this baby, and baby is about 28 hours old, and I'm a little concerned about the weight loss. All right, so we're just gonna play with this so you guys can kind of see how it works. And if you're familiar with it already, I do apologize. So we're gonna say this baby weighs about 3,300 grams, and kiddo was born yesterday morning, we'll say about 4:30. It was a vaginal birth, and that's an important point here. I want you to make sure you click on whether it's a vaginal or cesarean birth, and if the baby is exclusive breastfeeding. You can also use it for exclusive formula feeding babies, but for the sake of this afternoon's presentation, we're going to say it was a vaginal birth, exclusive breast milk feeding. All right, so the nurse reweighed the baby. I'm going to keep it at 2,900. I know that's not going to look great, but just for the sake of today's presentation. And she reweighed the baby today at about 5:30. And we're going to graph this weight. And if you notice, there is a green zone, a yellow zone, an orange zone, and a red zone. And you can kind of see where the baby plotted at 24 hours. It looks at the baby's percentage of weight loss in relation to the number of hours. And I know you can't see the x-axis here, but down here it would be how many hours old the baby is. And if you look over here, it tells you the baby lost 12.1% of its birth weight at the 24-hour, 25-hour mark. Now, there are things, sometimes I'll go back and make sure the birth weight was entered correctly. Sometimes we'll reweigh the baby to make sure, particularly when I'm starting to see 9, 10, 11, 12% weight loss. Let's reweigh the baby on a different scale. Let's just make sure it wasn't an error, data entry error, error with the scale, issue with the scale. If I see a baby that's way below the red mark or the red zone, I really need to have a conversation with the pediatric provider and the parents about supplementing, but also expression. Mom needs to start expressing. Now, let's edit this, and let's say the baby weighed 3150 when she weighed the baby this morning at 5:30. And the baby's in the green zone. This looks good. I'm not going to mess around with it. I'm going to encourage her to keep doing what she's doing. Keep the baby skin to skin, hand express, and keep offering the baby based on early feeding cues. But if I'm in the orange, red zone, it's our due diligence to have that conversation with the pediatric provider and the family about maybe throwing in some expression and supplementation. If the baby's kind of in the yellow zone, I might say to mom, let's try to wake the baby up a little more often. Let's try to hand express into a spoon and do some spoon feeding or cup feeding or whatever alternative method you're using. And let's reweigh the baby and see where the baby is tomorrow morning and see how the baby's trending. So it is important to watch the trend. So now I realize if it's a vaginal delivery, some families may be going home at the 24-hour mark. If the family is going to stay another night, the nice thing is you've got another data point to plot, and you can see, is baby following their curve or is baby drifting down? So this is a tool to help you kind of say, maybe we do need to think about expression that not only includes hand expression, but utilizing your pump. So I just wanted to show that to you as a tool. The other tool that's out there is the Billy tool. And I'm not going to belabor it. I think if we're working with newborns, most facilities and places where I work or consult with have the Billy tool incorporated into their electronic medical record system. And the providers and clinicians at the bedside are very familiar with it. But it's also a great tool because it looks at the baby's bilirubin level in relation to time and risk factors. So if the baby is jaundiced and does require, well, let me retract that. If the baby's jaundice level requires phototherapy, I think it's prudent to get mom to start pumping and supplementing with express breast milk. Other factors to consider, and when I'm having this conversation with you, I am speaking more to the healthy term infant. I have had parents say to me, baby's not getting anything, so we're supplementing with formula. They're supplementing because their belief is there's no milk. I get that a lot. And so making sure that they know how to hand express effectively and can see the colostrum or the transitional milk being expressed is very reassuring. So sometimes what I'll say to them is, let's go over this. Let me show you. I've also had moms tell me, I've been hand expressing and nothing's coming out. And what I find again, she's compressing the heck out of her nipple, but she's not really compressing the breast tissue, and she doesn't really understand how to effectively hand express. So it's really important to make sure all mothers know how to hand express effectively. It's really important to make sure the family understands the physiology of lactation in the first few days, that it's small amounts of colostrum, that it's very viscous, and that they're going to see more and more, and they're going to see it become less viscous as the days go by. And I can't emphasize that enough. And I spend a lot of time with my families doing just that. So if you need a refresher, or you just want mom to take a quick look on, and most of my families, I have to say, have a smartphone, some type of pad, laptop at the bedside. Don't hesitate to let them, watch some videos on hand expression and go over it with them in real time. Sometimes what I'll do with a mother is I'll put my gloved hand directly on their breast and have her put her hand on top of my hand so she can kind of feel what I'm doing and feel the motion, and that helps them get it too. UNICEF UK Baby Friendly Initiative has a nice video. It's less than 5 minutes long. And the Stanford Medicine one, the hand expression with Jane Morton, it's been around for a while and it's a little bit longer, but it's a really good video. So don't hesitate to use your resources. And a lot of families respond well to video. They learn better watching videos. Now, so I was discussing the healthy term baby. We have to talk about the near term or late preterm babies, particularly the ones that get to hang out on the unit with the parents. They're rooming in and they look good in the delivery room. APGARs look good. And 12 to 36 hours out, I start to see these kids kind of crump. One of my mentors in lactation years ago, she said, oh, we call them the great pretenders. And there's a song from the 50s called, oh yes, I'm the great pretender. Anyway, I'm dating my mentor. But they start out looking good. APGARs are good. They're rooming in. All is well. But when you take a closer look and you look at your assessment findings, you realize they're not doing as well. It could be the blood glucose level. Most kids that are less than 2.5 kilos or preterm are going to be having their glucose levels checked. It could be the weight loss at 24 hours. It could be I'm just watching this baby at the breast and mom's like, oh yeah, he's doing great. And I'm watching this baby and this baby is I call it sometimes nippling. Baby's latched on the nipple and isn't really grasping the breast tissue and isn't really transferring milk. And parents who have their baby in the room and the baby didn't have to go to the NICU or special care kind of look at me and go, well, what do you mean? Everything's fine, right? And I'm like, everything's fine, but we probably need to talk about doing some supplementation and getting you started pumping. So this gets sticky too. So this requires some finesse and conversations with the pediatric providers and the nurses taking care of the family, and kind of making sure everybody's singing the same song and that the parents are on board with the plan. And that can get sticky too. I do have some parents like, no, absolutely not. We're not doing any of this. This baby's just going to breastfeed exclusively, and kind of helping them see that the baby needs a little more support. And this isn't a forever thing. And as the baby's getting stronger and more coordinated, we'll wean off of the supplementation and pumping. And we'll get to a place where you're just supplementing with some pump breast milk and pumping because you want to, not because you have to. So that's a slippery slope sometimes, that discussion. Now, again, if the family's separated, that is kind of a no-brainer. We need to help her express. And the sooner you can get that started, the better. I do realize there's complications. So I realize ideally we should get her started expressing and pumping within an hour of delivery. But if there's a lot going on and there is a massive hemorrhage, or she does have to go back to the OR, it may not be opportune, but please get her started as soon as possible. And the other thing too is, once you can help get the pump in the room and get things initiated, is she stable enough? Is she able to do this independently? Or is she gonna need help? Is she gonna be a mom who requires full assistance? This is tough. Is her partner gonna be able to stay and help her with this? Is the healthcare team gonna be able to stay and help her with this? And if they are, how often? So you have to come up with sustainable expression plans. I had a family, and this was several years ago, and the mother had massive postpartum hemorrhage, had to have a hysterectomy in the OR, and she was transferred to our intensive care unit. And I think it had only been 12 hours since she delivered. And I went upstairs to see her, and her mother, she was stable enough for her mother and her sister to be at the bedside. And this was years ago, pre-pandemic. And so she was allowed to have 2 visitors in the room. And when I got up to the room, she was on her 24th unit of packed RBCs. And I was like, wow, okay. And the mother and sister looked at me and said, she breastfed her first baby for 2 years. And we know how important breastfeeding is. We know how important the breast milk is. And we need to get her started pumping. And I said, absolutely. And we came up with a plan where the mother and sister pumped her, because the mother was sedated and restrained, intubated. There was no way the mother was going to be able to express or pump. And I went over everything with the mother and sister, and the nurses even helped out. And it was amazing. So the next day I went to see her, and she had deteriorated some more. And she was in acute renal failure, and she was on dialysis. And the sister and mother looked at me and they said, nothing's happening, nothing's. I said, stay with it, just keep doing what you're doing. We reviewed everything. We made sure the pump was working properly, looked at technique, flanges, the works. So I won't belabor the point, but I worked with this family for several weeks, and I was concerned about Sheehan syndrome because she had lost so much blood and she was in such critical condition. I'm happy to report that she was able to pump. She was not able to produce all the baby's needs, but she was able to produce about 50 to 75% of the milk that the baby took in. And the day before she left the hospital, I was happy to see her in her room on the postpartum unit. She'd been moved back downstairs and nursing her baby. So it's tough, it's not easy, but it can be done. And it definitely was to her benefit that her sister and her mother were so supportive and really did the work. And I really have to applaud the ICU nurses up there too. They were doing an amazing job. So kind of remember, the mother that is separated from her baby is going to need some extra support. And we do need to look at what's sustainable and what's realistic. I've worked with some families during the pandemic. No one was allowed to be in the room with the mother with COVID, and that was tough. But I had some amazing ICU nurses and ICU providers that help mothers with massage, hand expression, and pumping. And I was just overwhelmed by how amazing these healthcare professionals were and the work that they did. So it's not easy, but we can make it happen. It's a team effort. Initiation and frequency of expression. Again, ideally, you want to get it started within 1 to 2 hours of delivery. I realize that doesn't always happen, but get it started as soon as possible. Ideally, too, we want this family doing the hand expression and pumping at least 8 times in 24 hours. And if it's not sustainable, I'll talk to the family, I'll talk to the healthcare team, and like, can we do this at least every 4 hours? And if she's feeling better and she's getting stronger, bump it up to 8. Can she pump both breasts simultaneously? Sometimes the equipment and everything that mom's hooked up to, it's not feasible. So sometimes we do have to pump one breast at a time. Can she pump for at least 15 minutes? That's another issue. And what modifications can we make to help her be comfortable and sustain the pumping plan? So again, this is something we have to consider for our moms that are critically ill. If the baby's in the NICU and mom's stable, it's not so much of an issue, and many mothers are motivated to do this. However, I do have some moms that get tired and they are exhausted, and I'll tell them 8 is great, and they'll be like, I only pumped 4 times yesterday. And I'm like, okay, let's have that conversation. What can we do to help you? So things I like to go over during the initial visit and follow visits: is the pump being used correctly? Is there a pump available with initiation technology? Which is great because she can use that to really maximize the technology that's available to her. Are the breast shields or flanges fitting her properly? Is the family able to bring in a bra or a bustier or something to help her pump hands-free? I get this complaint a lot from moms: the IV's in one hand, my hands are swollen, my hands are getting tired, my wrists are getting tired. Holding the pump flanges, the breast shields in place for 15 to 20 minutes is a lot of work on your hands. The healthcare team, think about that too. It's hard. I don't know how you're staffed at your facilities, but it is hard to get a hold of a lactation consultant sometimes, or it's the middle of the night and they're not readily available. So it's really important for the team to recognize the maternal and neonatal risk factors at play. It's really important to get mom started expressing and pumping if there's good indication for that, or the families, the mother and baby are separated. Don't wait for the lactation consultant to get on the floor at 8 a.m. If she delivered at 11 p.m., ideally by 1 a.m., she's hand expressing and pumping. She shouldn't be waiting for the lactation consultant to hit the floor for that. So look at the risk factors. Sometimes it's easy, mom and baby are separated, but sometimes it's not so easy. And if the baby's on a hypoglycemia protocol, for example, and the baby's blood glucose levels aren't stable, she's a good candidate to get started expressing and pumping. So I see this a lot in clinical practice where there are delays in initiating expression and pumping. And I say that to say pumping is a form of expression in addition to hand expression. But I get to the floor and I see that and I get frustrated sometimes. So my colleagues and I kind of sat down and collaborated, and they were like, hey, is there any way you could kind of come up with an algorithm or a tool to help us know when it's a good idea to start mom expressing and pumping? And I'm like, okay, let's look at that. And the whole purpose of this tool was not to say that the family wasn't going to be seen by a lactation consultant or a breastfeeding specialist, but it was to say, hey, can you give us a tool to help us out until you can get in there and see them and make other recommendations? So this is a sample of a tool that I created and piloted at one of the hospitals I worked at. So the first question was, is the baby in the NICU? So to the left of my screen that I'm looking at, yes. And the next question is, can the parent who gave birth to the NICU go to the NICU to feed the baby? Okay, and you can kind of see it goes down, down, down. All right, if you look to the right, or I'm looking at my right, is the infant late preterm? That's what LPT, hypoglycemic jaundice, was a supplement ordered? So I've got a yes, no question there, or I'm sorry, a yes and a no flow chart there. So let's go back to the left side and we'll just kind of run down it together. Can the baby who gave birth to the NICU go to feed the baby? No. Initiate pump. every 3 hours or about 8 times in 24 hours. And there's a little handout on pumping that I left them. If the answer is yes, and she can go to the NICU, does the infant require supplementation after breastfeeding? If the answer is no, we're going to go down to the bottom of the tool and you'll see breastfeed ad lib, place baby skin to skin, blah, blah, blah. If the answer is yes, we're going to initiate a triple feeding plan. And I gave the nurses and docs a triple feeding plan template. All right, now I put a little caveat there under triple feeding plan, which is what TFP stands for, is you're going to supplement per the provider's orders, okay? If there's not a specified amount, we recommend 5 to 10 milliliters per kilogram based on the baby's birth weight, okay? We just referenced that handout on triple feeding plan. Now we're going to go back over to the right side. Is the baby in NICU? No. So baby's rooming in. Now, is the baby late preterm, hypoglycemic, jaundice? Was a supplement ordered? Okay. Did they use the newborn weight loss tool? Was the baby in the orange or the red zone? If the answer is yes, they can initiate a triple feeding plan. If the answer is no, do the parents desire supplementation after breastfeeding is the next question. If the answer is yes, we'll start a triple feeding plan. If the answer is no, the arrow goes down to the bottom, which is breastfeed ad lib, place skin to skin, hand express, yada, yada, yada. All right. You're going to have several questions about this. I have had parents tell me, we are breastfeeding, but we are also formula feeding, and we are going to give some formula after each feeding. And no matter how much education I do, the parents are just set in stone that this is going to be their feeding plan. So if that is their plan, I recommend a triple feeding plan. The next slide, I'm going to show you what that triple feeding plan looks like. But the triple feeding plan is great if there's excessive weight loss. It's great if the kid's hypoglycemic or jaundice. It's great for my late preterm, near-term babies that are kind of like, well, I like breastfeeding, but I get tired and I'm not able to really be consistent and sustain that latch. As some of my kids look at me and go, you know, I'm just not sure I'm ready for all this yet. And I'm looking back at the kid going, yeah, you got a point. You were probably supposed to be in the uterus for another 2 or 3 weeks. But anyway, let's kind of go to the next slide so I can help you understand what that triple feeding plan looks like. All right, this is just a blurb, an excerpt, if you will, from what I had developed at one of the hospitals I worked at. And it was based off of, I shouldn't say developed, I pulled from the literature and I looked at triple feeding plans that I had seen from other healthcare organizations. But basically what it is it's kind of helping mom make sure the baby eats about every 3 hours. And there's 3 steps to it. So there's where the triple feed or triple feeding name comes from. Then step 1 is keep the baby skin to skin. Offer the breast for up to 30 minutes. Focus on breastfeeding on one side. Sometimes they're really determined to make sure they offer each breast, but it's okay. I would rather they not interrupt the baby. If the baby wants to feed for 20, 25 minutes on one side, as long as it's a comfortable latch, it's a good latch, baby sustaining it, why in the world would I interrupt it and throw that baby off keel? They can feed from the next side at the next feeding. And it's perfectly natural and normal for a baby to feed on one side. And then step 2 is after they've spent the time skin to skin and offered the breast, have the family member give the baby blank. And I left that blank because it's a template, milliliters of your pumped milk, donor breast milk if you have that available, or formula if she's not able to pump or express the volume needed for the supplement. If she's alone, she can feed the baby the supplement first, but there has to be a step 3. And this is where the mom is going to pump, ideally both breasts at the same time for 15 minutes. If she's using the the initiation program on the Symphony breast pump, it's going to cut off at 15 minutes. When she doesn't need to use the initiation setting anymore, I may write in there 15 to 20 minutes. She's going to save that breast milk for the next feeding. So this is important for them to understand. They're pumping ahead for the next feeding. And the idea is to get all 3 of those steps done within an hour, because before she knows it, it's going to be time to start that whole process again. And I don't want them to run into one another. And I also do add a caveat at the end, or a statement, that they really need to make sure they follow up with their baby's pediatrician and their outpatient lactation consultant, because they're going to want to wean off the plan. It's really hard to maintain this plan for more than a few days. And the idea behind the triple feeding plan is, hopefully by day 3, day 4, milk's coming in, baby's more alert, baby's more engaged, baby's transferring better, baby's weight loss is stabilized. If we're doing this for hypoglycemia, the glucose is stabilized. If it's hyperbilirubinemia, the bilirubin levels have stabilized. We're getting the baby off phototherapy if the baby was on phototherapy, that type of thing. So I always tell the parents and the family members, this is a plan to help you transition. It is not a forever plan, because this is daunting and it's a lot of work. And the more support she has cleaning the pump parts, setting up the pump, the better. And it was tough during the pandemic because not everyone had support and was allowed visitors to help them out, or visitation was limited. So a tool for our toolbox, a triple feeding plan. Another tool that I gave them, and it was too difficult to copy it all for the purposes of the time we have, which I can't believe is almost up. A pumping plan is very helpful. Some of my mothers like paper and pencil, some of my moms like apps, but I still had a pumping plan on one sheet of paper. I kept it as simple as possible. On the flip side of that sheet of paper was a log, a paper log. So if she preferred to write down how much milk she was expressing at each pumping session, she could use that. And basically what we wrote on that template was, the goal is to pump every 2 to 4 hours, both breasts at the same time for 15 to 20 minutes. You want to pump at least 8 times in 24 hours. I would always tell my moms 8 is great. If she can get 9 or 10 pumping sessions, and that's even better. We also encourage our moms to pump more frequently during the day and less frequently overnight. And what I've also encouraged them in the nighttime is, if they know the nurse comes in at 10 p.m., 2 a.m., and 6 a.m. to do vital signs, they might want to coordinate those overnight pumping sessions with when the nurses are coming in. Or they might want to coordinate it with the time the nurse comes in with medications. What I'm trying to do with that, the premise behind that, is trying to minimize the interruptions in the mother's sleep cycle. Sleep deprivation is very cruel and very real and very stressful for mothers. So a pumping plan, you can play around with it, you can make it a template. I've seen several out there, but this can be very helpful, particularly when you have a mother who has a baby in the NICU, particularly when you have a mother who's up in the ICU. So this is different from the triple feeding plan, which is coordinating the baby's feedings with the expression. This pumping plan is more for the mother who's separated from her baby, or the mother who's going home from the hospital and the baby's going to have to stay. And I think the moral of this story is, whatever plans, whatever decision trees, decision-making algorithms you come up with, make sure they're evidence-based. And make sure you're looking at risk factors, and look at the antepartum course, the intrapartum course, the postpartum course, and the neonatal course. And also when you're trying to create these plans and these tools, I strongly encourage you to make it an interdisciplinary team. You really want everybody's input. You want to make sure everybody's on the same page, so to speak, that we're all singing from the same songbook. And look at your policies, look at your protocols. Are they up to date? You know, are there any issues with currency? Is the evidence that they were based on current? And the other thing too is families shouldn't have to wait for an evaluation by a lactation consultant or a breastfeeding specialist to get the ball rolling. It's 1 a.m. You know that baby's going to the NICU. Baby may be shipped out to a children's hospital nearby. Baby may need emergency surgery. Help her as soon as it's feasible, as soon as she's stable, with breast massage, hand expression, and using the pump. It's a team effort. And it's really important we're all working together and supporting one another. And I think we've really learned this during the pandemic. So I think, let's see, hopefully I didn't use my time. And there are some references for you, and I did check and make sure the links work for you. So I think I did a decent job with timing, and I do apologize. I was trying to scroll up and down with my keyboard, and that was not working, so I realized I had to use my mouse on the lower left side. Anyway, we have time for questions, so please feel free to
Thank
chime
you,
in.
Darlene, for that information. We do have quite a bit of questions coming in, so we'll try to get to all of them. One question that I see coming through is if your handouts, both the triple feeding plan and the handout on pumping plan, would be available to give to the attendees on the call today.
That is a wonderful question, and I will do my best to send some samples. I have to be careful about intellectual property and copyright for the facilities that I've worked for, but I can do my due diligence to send some things out.
Okay, whatever you have available, if you're able to share it, you can send it to me, and then I'll make sure that attendees do get it. I'll include it in on an email that I send out. So that would be great. Thank you.
You're welcome.
You're welcome. The first question is, what is the current research regarding using the second day 24-hour weight rather than the birth date weight?
This is where that newborn weight loss tool comes in handy. And I really would encourage you to use it. It's an evidence-based tool, and there's a lot of research behind it. And when you go to the website, and I do apologize, I didn't get a chance to show you guys, there is a link where you can see all the evidence behind it. And so it was developed, I want to say Penn State, Kaiser Permanente, and a healthcare organization out in California. I would encourage you, because you can use it up to day 3, day 4, and you can trend the baby's weight loss, and you can see if the baby's in the green, yellow, orange, or red zone, and come up with a plan. I hope that answered your question.
Thank you. There is another question, several questions actually on the calculator you showed. This one is, there is only an exclusive breastfed or formula-fed baby section. What about babies who had both? Would this calculator be helpful?
Excellent question. Yes. If you go into and look at the instructions on how to use it, if the baby's gotten supplemented with formula, what you can do is click on exclusive formula. I realize the baby's also getting breast milk, but if you click on that button, that will trend it for you.
Okay, thank you. Next question is, what's the maximum amount of time you'd leave a baby without a first feed?
Excellent question. So I hate to say it, it depends. It's not clear cut. If it's a late preterm baby, I really want to see that baby that's rooming in, it's near term or late preterm, one solid breastfeed within the first 6 hours. Mind you, that baby's also probably getting glucose checks, and hopefully you have a glucose protocol. So I would say at least one in the first 6 hours. For near term, preterm babies, I tend to want to see at least two in the first 6 hours. For healthy term newborn babies, there's no issues with hypoglycemia. The baby's not Coombs positive, hyperbilirubinemia. I would like to see at least one effective breastfeed in the first 12 hours. That doesn't mean I don't want the parents trying about every 2 to 3 hours, and I definitely want them expressing colostrum and placing the drops of colostrum on the baby's lips and gums, or spoon feeding or cup feeding. So the answer to that question is it's a very gray area. Use your judgment. And I would say within the first 6 hours, if you still haven't seen a good latch and that baby hasn't sustained a feed for at least 5 minutes, it would behoove you to express and spoon or cup feed that baby some expressed colostrum.
Okay, thank you. The next question is milk expression and supplementation indicated when a baby is jaundiced but diaper output is adequate?
If the baby's diaper output's adequate and the bilirubin's stable, the bilirubin level's stable, so you're looking at your bilirubin tool, and you're observing this baby with sustained latch, feeding well, transferring well. You've got, also look at your urine output. Babies that are jaundiced, especially those with phototherapy, may be a little dehydrated. I have had babies with jaundice, with phototherapy, breastfeed beautifully, and didn't require supplementation. But if I'm seeing that the bilirubin's not stabilizing, supplementation may most definitely is warranted. And the other thing too is it's a conversation to have with the provider. Sometimes we as nurses and lactation consultants, if we're not the provider, take on things that the provider really needs to collaborate with us on.
Okay, thank you for that. The next question is, can you use a newbornweight.org tool for preterm or late-term infants?
That's a great question. I have used it with my late preterm and near term infants on the postpartum unit, those that were rooming in. I have not used it in the neonatal intensive care unit or the special care nursery because I defer to the neonatology team. They have different parameters, and the stressors that those kids are going under, and the amount of supplement and the IV fluid kind of change the variables for them. So I don't use it in the NICU or the special care nursery, but I will use it with near term and late preterm infants on the maternity units.
Okay, thank you for that. Looks like we have time to squeeze in one more quick question, and that is, could you please comment about the issue of importance of providing suction to encourage the establishment of lactation production in the first days after birth that hand expression doesn't provide?
Can you repeat that for me, Kim?
Sure.
I want to make sure.
Could you please comment about the issue of importance of providing suction to encourage the establishment of lactation production in the first days after birth that hand expression does not provide?
Okay, so hand expression is wonderful. And if the baby is able to latch and sustain a latch and is transferring milk, I would encourage mom to just stick with the hand expression. But if I have a baby that is separated from the mother, that is not sustaining a latch, that is not demonstrating adequate milk transfer, the initiation of a pump with the suction that a pump can provide is important, because if the baby's not able to provide the stimulation, I need the pump to kind of act like the baby and create that level of suction and stimulation that the breast needs. The breast needs those messages to get that milk supply to come in. I hope that answered the question.
Yes, that sounded great. Thank you so much. Looks like we are already at the top of the hour. That hour went very fast. Just a couple quick things before we end for the day. Just a reminder, your certificates will be available this Friday by logging into your account. Once the webinar ends today, a separate window will open up with the evaluation. So please make sure you fill that out in order to get your nursing contact hour. And registration is available for our August 30th special webinar and the September 14th webinar. You can go to medilaeducation.com to learn more about those and to register. And I hope everyone has a great afternoon. Thank you so much. Thank you, Darlene.
Thank you, Kim.